name is Shantanae Dillard. I'm a community health worker, and I am sharing a story about my loss of my son at 8 months. The situation that happened was I was the personal care attendant for my own son. He had many disabilities, spina bifida, hydrocephalus, club feet, and seizures, aspiration and reflux, just to name a few.
A visiting nurse helped Shantanae monitor her baby's care. One day, they noticed drainage and leakage in the baby's feeding tube. Shantanae saw a gastroenterologist and primary care physician, and they checked the feeding tube and didn't find a problem. They performed laboratory tests and told Shantanae they would inform her of the results.
I never heard of the results. 2 days later, on June 26, 2008, my son, I woke up to a dead baby.
Paramedics were called and her baby was taken away on an ambulance. She was told they would perform an autopsy to find out what happened, but never did.
I think that right was taken away unjustly and that it shouldn't have been done. I still deal with it to this day. I don't have answers. And I feel like, in a way, I felt my child. And I just try and erase the memories on a daily basis. I don't think of it. I don't think about the baby. And there's no ending to that story.
Infant mortality is defined as the death of an infant before their first birthday. Why is infant mortality important in public health? Infant mortality is what is called a sentinel measure of population health. That means on the basis of the health of our babies, we can tell how an entire population or community is doing and the quality of health care that they are receiving. Infant mortality rate is defined as the number of deaths for every 1,000 babies born alive. For the years 2015 to 2017, the infant mortality rate for the U.S. was 5.9. That means 6 deaths out of 1,000 live births. Minnesota's infant mortality rate of 5.0 is below the national rate and below the Healthy People 2020 target. So, as a state, not too bad, but the story changes when we look at certain groups. According to the U.S. Centers for Disease Control data, the infant mortality rate for non-Hispanic Blacks in 2017 was 11.64. Compare that to the rate for whites of 4.61 in the same year. In Minnesota, the infant mortality rate in 2017 for non-Hispanic Blacks was 9.35 versus 3.58 for non-Hispanic whites. That means Black babies are more than twice as likely to die as white babies before their first birthday. And it's worse than Hennepin County, which has the largest concentration of African Americans in Minnesota. African American infants here are more than 3 times as likely to die as white babies. And within the African American population in Hennepin County, there's a difference in the infant mortality rate among U.S-born versus foreign-born African Americans. The rate among mothers born in the U.S. is almost twice that among mothers born in a foreign country. They call it the healthy immigrant effect, that immigrant cultures have protective features that give foreign-born mothers better reproductive health overall. Why are we losing our African American babies? These are the top 4 causes in Minnesota based on data from 2012 to 2016. The number 1 cause, comprising a little over a quarter of infant deaths, is prematurity. That's when a pregnancy does not go full term and the baby is born before 37 weeks. A close second, 23% of infant deaths, is congenital anomalies, also referred to as birth defects. Next are sudden and unexpected deaths at 16%, and obstetric conditions or problems during pregnancy or birth at 12%. But this still doesn't answer the question why African American babies are dying at higher rates. This model of what creates health provides some explanation. Social, economic, and environmental factors comprise roughly 50% of what determines our health. These are things like education, income, housing, transportation, public safety, neighborhood amenities such as parks and sidewalks, healthcare access, or social connectedness. Next is our behavior, so our actions as individuals, such as not eating healthy, can impact our health by a measure of 30%. Those things we can control to some extent, but not the other factors. They're the things we're born with, our genes and biology, that coupled with the healthcare we receive, together make up 20% of our health. Still, they don't affect our health as much as the social, economic, and environmental factors.
I think that the reason that I would like to share my story and what I think that others should take from this is that it's very crucial to have support for the parents who has lost a child at the time of the loss and immediately after, and also for them to be able to access resources.
My name is Helen Jackson Lockett-L. I am the Community Engagement Planner at the Minnesota Department of Health Center for Health Equity. I am the coordinator of a project at the center that focuses on U.S.-born African American infant mortality in Hennepin County in Minnesota. One of the main goals of the project is to strengthen the capacity of the U.S.-born African American community to change the conditions under which babies are born. We're doing this in a number of ways, and two of them are about activating the community to engage them in an organized change efforts to create change. The first is Community Voices and Solutions, really known as CVAS, our project leadership team that leads all the planning, implementation of the project activities. We currently have 19 members who are community leaders in their own right and represent various sectors encompassing the social determinants of health. The second is the community co-learning, which is what this documentary is all about. The goal of the community co-learning is to deepen the community's understanding of the structural determinants of the African American infant mortality and to motivate co-learning participants to take action to change the policies and systems that perpetuate infant mortality rates and the disparities that we see.
Social determinants of health are the conditions in which people are born, grow, live, work, and age. They are determined at the policy and systems level by those who have the power, sometimes money, to make decisions. Research suggests that social determinants contribute to health disparities and that racism is a probable underlying determinant of these conditions. Why should we care about social determinants of health when it comes to infant mortality? Because the populations most impacted by high infant mortality rates, African Americans and American Indians, also happen to be at the greatest disadvantage when it comes to assuring them the optimal conditions for health. And it happens way before the baby is born, during the mother's lifespan. And here's what research says about that. During pregnancy, implicit racial bias may cause doctors to spend less time with African American patients, to provide less effective care to them, and more likely to underestimate their pain, ignore their symptoms, and dismiss their complaints. During infancy, African American babies receive worse quality care in neonatal intensive care units compared to white babies. During childhood and adolescence, African American families are offered fewer adequate housing options than white families and are more likely to live in substandard housing with environmental toxins such as lead, mold, or radon. And throughout school, African American girls are more likely to be suspended or expelled than their non-Hispanic white female peers for similar behaviors. And during adulthood, once they enter the workforce, African American women earn only 63 cents for every dollar earned by white men. They are also more likely to work in jobs that lack structural supports, including flexible scheduling, paid sick days, paid family leave, and an optimal duration of paid maternity leave.
My name is Clara Sharp. I am a doula with Ahava Birthworks. I'm going to tell a story about two women who I supported both their births that were within 2 weeks of each other.
This is the tale of two women, one Caucasian mother and one African American mother. Both wanted a natural birth, and it was the third child for both. The Caucasian mother did not have a lot of prenatal care and was confident that she knew her body best. The African American mother did have prenatal care, but switched to hospitals at the last minute, and her medical records were not sent immediately to the new hospital. The Caucasian mother did as much of the labor at home as instructed, and when she got to the hospital, had her baby within an hour. The African American mother, the same exact story, did as much of the labor at home as instructed, and then when she got to the hospital, had her baby within the hour.
Right away, they're questioning her. Why aren't there any medical records? Are you on drugs? We need to take a urine test. If we don't get permission to take a urine test from you, we're going to get it from the baby. They criminalized her. They treated her horrible. They were asking her, why did she have her baby so quick? What kind of drugs was she on? Was she taking cocaine? Was she smoking marijuana? Because this is not typical. Most moms labor for a long time, and also she was having her third child. So very similar, and also around the same age. But this mother's African American. After the nurses left, she and I talked. She's like, Miss Claire, they're making me feel terrible. I can't believe this is happening to me. And I said, you need to advocate for yourself. You need to talk to someone. And I'm going to let them know too. They remember me from last week. And I talked to the head of the nurse department, and I said, look at the records. You will see that I was here with this client. I gave them the name of the client. And I said, look at her records, and you will see it's the same as this mother. Why are you doing her like this Black mom? Why are you treating her this way? They're like, oh my gosh, we're so sorry. We didn't realize that she had doula services. We didn't realize that it was like they were caught doing the wrong thing. So they offered her a care package, free pictures, and I'm like, that's not good enough. You need to make a formal report. If you don't, I will, to my client. She did make a report to this hospital, what had happened, and the mother previously had wrote her situation, the white mom, because I wanted both of them to document what had happened. So they both did that, and yeah, that was that story.
For the co-learning participants, we recruited 22 community members with a passion for advocating for healthy babies in the community, and they were excited. They're community health workers, doulas, social workers, health program administrators, moms, students, fathers, and even a few grandfathers. We did 2 rounds of co-learning with 2 cohorts of participants in each round. They were educational sessions where they learned about social determinants of health and social determinants of infant mortality, organizing community power, and infant mortality programs around the country that have successfully used social determinants of health strategies. Participants brainstormed strategies for addressing African American infant mortality. At the end, they selected one strategy focused on systems change that they implemented as a mini project and created an action plan for the project.
The co-learning participants, working individually and in groups, implemented 4 mini projects. 1, enhancing the state's community health worker curriculum to include more maternal and child health topics and training. The second one was developing recommendations for building a maternity home that would provide holistic services to pregnant African American women from their first trimester through 8 weeks postpartum. The third was developing a youth-led health curriculum targeted to 15 and 25-year-olds. And the last project was using community radio to increase access to health information with a focus on the role of men in pregnancy and child rearing.
Hello, my name is Mitchell Davis. I'm a husband, a father, a grandfather, business owner, and an advocate for health equity in our African American community. Now, I have a strong interest in infant mortality because I was a 3-pounder at birth. I've grown a lot since then. I'm now about 230 pounds and 6 feet 6 inches. And I've worked on this co-learning mini project with 6 other people who are doulas and social workers, mothers, faith leaders, fathers, community health workers. And our meetings were punctuated with babies gurgling and laughing and crying and eating too, which reminded us so much of why we were engaged in this mini project.
My name is Khalees Allen, and I'm a member of Cohort 5, working on infant mortality in Hennepin County. I have a strong interest in infant mortality because it's something that really impacts my community and doesn't get talked about a lot. We chose this mini project because we wanted to take all the information that we learned and voices from the community to folks who are making policy. At the end of our project, we hope to have influenced policy that will positively impact infant mortality.
My name is Sophia Thompson. I work at Ramsey County Human Services in our adult mental health program. At the start of this project, I was in child protection where I had been for about 10 years. Part of the reason I was interested in the infant mortality opportunity to learn in the co-learning sessions was because of the work I had done with various women and children in the work at Ramsey County and prior to. I would hear stories of women who had lost their children in late stages of pregnancy and shortly after. I would learn about the different economic challenges, the living circumstances, the lack of prenatal care that these women endured that potentially contributed to losing their child. I really wanted to learn more, and this program gave me that opportunity. I was very fortunate to be around a group of great, amazing women who came from various backgrounds in the community and a lot of different skill sets. That was one of the things I enjoyed most about the co-learning sessions.
Hello, my name is Rebecca Nathan. I am an instructional designer. Most of my work is focused in the area of helping others build skills around racial and social justice in the education system. A lot of my work has focused on early childhood, but also a significant amount in K through 8 education, Afrocentric education, and family education. So that work shows up in many different sort of arenas, but that's kind of the crux of my work. My interest in the African American infant mortality rate stems from a strong kind of core that drives my work in the first place, which is my belief that African American children deserve to have assumed innocence. They deserve to have so many of the privileges that children of other groups have automatically and without interruption. And my belief that African American children are like beautiful and amazing and creative, as are other children. However, with African American children, that's not the narrative, and that's heartbreaking for me. So the African American infant mortality rate is one important angle of that heartbreak for me, and I wanted to learn more deeply about it. I was involved in a community cohort where we came together and learned more deeply about the issue over time.
My name is Clarence Jones, and I'm a community health strategist with the Human Partnership, but also a member of Cohort 3 working on fatherhood engagement. I've had a strong interest in infant mortality since hearing my first public presentation about the issue. I have seen and personally felt the devastation that it can have the lives of families and parents that have undergone this tragedy.
Our co-learning project started with the idea of having a maternity home. This maternity home would be a place where women could come at the mid to late stages of pregnancy, and then shortly after delivering their babies would be able to stay for 6 to 8 weeks until they could get on their feet and have a decent place to live after delivering and giving birth. The idea was that we would be able to support them in this journey and they wouldn't have to do it alone. We knew that our project was ambitious, that we would have a lot of capital to raise and a lot of people to believe in this mission.
The mini project that I am working on, I'm not finished yet, involves recreating the same experience that I had in the cohort, essentially, with an intentionality to have it led by youth, ages 15 to 25. And the idea there is that if young people can take up the learning and share it with others who aren't necessarily privy to that information based on their job or something that they're personally working on, it can really shift the mindset of the next generation who are making decisions and who are voting and other important things. The project is really designed to not just ask young people to consider these ideas, but to take action in ways that are relevant to young people. So it really relies on social media and capturing their thoughts, asking them to think in ways that are more intuitive for young people. And that makes it really innovative and exciting in my mind.
Our focus was focusing on enhancing the community health worker curriculum with an expanded maternal and child health that is much more culturally specific to African American health. Our ideas as we thought about the project was we did a lot of brainstorming together and we came up with these topics: homelessness and its impact on mothers and babies, lack of health insurance for prenatal visits, food insecurity, birthing in correctional facilities, hosting doula advocacy days at the Minnesota legislature, and income for our dads and moms so they could provide for the family. We eventually finally honed in and focused on improving and expanding the community health worker curricula and practicum, and really having a focus of African American maternal that would drive home the fact that our curricula really need to be redesigned here in Minnesota. The areas that we hope to achieve at the end of the mini project, I believe we did achieve them, and of course there's a final report that talks in much more detail. But I view the mini project as not ending, but a launching pad to equip our African American moms and dads with meaningful and culturally enabling care at birth. Because this is not a linear process when we have children, but it's one that evolves to improve the health of mom and dad and child.
We chose to be involved in this mini project because we wanted to make the community aware of the various ways to include fathers in the discussions around infant mortality. We needed to inform both men and their families of the importance of men in the birthing process. At the end of this mini project, we shared with the community a series of topics regarding the importance of men in the birthing process, with the hope that everyone could have a clear understanding of how fathers may be engaged in keeping both mothers and their unborn child healthier.
They really drew on their own gifts and talents and strengths when they select the mini projects. We're also proud of the co-learning participant. They took their one strategy and ran with it, and they were excited about their mini projects. They were able to do so much with so little. We were able to provide a small stipend for all the participants. So we were really able to leverage our limited resource into something significant and valuable. But their passion and commitment are priceless. They dug deep and came up with a strategy that would change system for the better. They knew going in that they would be a lot of work, yet they anticipated and prepared for those challenges, and I give all kudos to them because they were exceptional.
In our hearts and in our minds, we knew that what we wanted to do was a great opportunity for African American and other Black and brown women in the community. But we needed the backing of people who had experienced this to see if we were on the right track.
Of the cohort learning is that it's a viable option for not just removed decision makers to get to make all of the decisions and actions, but to have it be from the ground up and have community voice what matters to them, and then provide resources for them to put it into place.
The advice I'd give as we close out this interview is just do it. Community co-learning approach works because it brings families together. It brings those who have the experience and training together, so we're all learning together. Now, it's two, I would say, funders of maternal and child programs need to pay more attention to the role of dads, because I believe there's a growing interest in engaging fathers, but there's so limited research showing the contribution of dads to good baby and family outcomes. And now for our moms of color need to see other women of color who are therapists and doctors and medical caregivers and nurse practitioners and physicians, doulas, community health workers, and also therapists. We know that when the services provided fit with the population served culturally, there's a higher chance that our moms and dads will start and stay with prenatal care.
I would find individuals in your community who are really, really doing the work. And what I mean by that, there are those treasures that we have in our community that have made a commitment. They have a long, positive history. They have a long, productive history around dealing with families and dealing with men. And I would ask that you just give them the opportunity to be engaged at a higher level and provide them with enhanced education and more visibility. Thank you.
To do it, it's the only way to go. The community knows what it needs, and we need to really support that, and the community should be a part of the change.
Speaking as a project coordinator, I think there are three key things that made this community co-learning successful. One is having the passion for and the commitment to the issue that affects our community. Two is finding the right people that have the passion and the commitment to really see change within their community, and our community leadership team that had a hand in all of this. They walked with them through the entire project. Three is the trusting community leadership team that participated and gave the support throughout the mini project. The impact that it had is unbelievable. They are still talking about it. They lived it day in and day out. So who is best to figure the way out and what's needed within the community? These mini projects have shown what can happen if we hand over power to the community instead of allowing a lot of times the institutions to say what's needed for the community. They handled the problems and they came up with the solutions, and we are just happy about that and delighted that for all the people who participated in the mini projects, and kudos to all the community members who were part of that leadership team. Thank you.
To sum it up, Black infant mortality. African Americans have a unique history because of the residual effect of trauma from slavery. Years of enduring racism has been traumatic, requiring the need to have integrated care for our babies that is holistic. to ensure that our African American children can reach their full potential. Addressing racism, that is economic, social, educational, and environmental, is essential, making it necessary to address these long-standing inequitable conditions, once embedded in our communities for generations. Conditions that must be matched with public policy to support and reduce the rate of infant mortality. For our African American children, it is their birthright to be healthy. So supporting mothers in all aspects of their life is critical for a positive pregnancy. As we strengthen and amplify our community assets, we need to harness and build relationships in all of our community pockets. And as we work in partnership with everyone, including our men, a sometimes missing important voice needed to provide positive parenting for our children. We must work diligently to create the best solution and listen to all our partners to affirm and harness their wisdom and value proposition. As African American families, we are entitled to have quality care that is comprehensive, as messaged in this public discourse and future work by you in this CVAS narrative.